Hello, and you're very welcome to the Health Research Podcast, where today we are exploring how you communicate evidence to influence health policy and behaviour. This podcast is a production of the Health Research Board, which is Ireland's state agency for conducting and funding health and social care research. I'm your host, Dr. Claire O'Connell, and in this series we explore how research and evidence can shape better policies for the benefit of everyone, that's service users, communities, society at large. Now, I'm a firm believer in the power of clear communication. I reckon there are very few problems in life that can be made worse by good communication. So how we communicate about research really matters. And in our first episode, we are looking at how to communicate to influence health policy and behaviour. And joining us to talk about this are two distinguished guests. We have Professor Pete Lunn, who is head of the Behavioural Research Unit at the Economic and Social Research Institute here in Ireland. And we have Associate Professor Sara Burke, who is Director of the Centre for Health Policy and Management at Trinity College Dublin. Sarah and Pete, you are both very welcome to the podcast. We're delighted to have you here. So let's dive in. Does evidence really matter when policies are being shaped? And how much do policymakers rely on this evidence? I mean, is it the foundation or is it an influence? What are your thoughts, Pete?
My honest thoughts about that is that I can't answer the question because the variation is so great. So I've been doing evidence for policy now. My unit works directly for policymakers. We're funded by policymakers. We feed evidence directly into the policy system. And my experience over that time is that there are some policymakers who are commissioning and undertaking research and receiving the reports and watching the presentations with very little intention of actually using it. They're doing it to be seen to do it. But the good news is that they're very much the minority. And over the time I've been in the ESRI, as I say, it's nearly 20 years now, actually more and more I find that policymakers take evidence seriously. I think a lot of that is to do with the expansion of science, the expansion of higher education. Far more of them now have degrees and postgraduate degrees and so on. So part of it is all of that good stuff. But there's still great variation. I mean, a lot of the policymakers I work with are genuinely curious to find the answer to research questions that are going to help them make better policy. There are others who are much more cautious and are worried you're going to throw up a finding that makes their life awkward, that might cause them to have to fight for a resource or change their practice in some way, or, have a conversation with the unions about changing people's job roles or whatever it happens to be. But my experience is you get great variation. It really depends on the specific officers and decision makers you're dealing with rather than the system.
And Sarah, would you agree there that the same counts even, your work focuses more on health policy, so even within health policy, would you see that variation as well?
Absolutely. And my initial response to your question would be, it really depends on who's making the policy and who's driving the policy. But I was thinking in advance today of areas where it has worked. So I think there's one thing is we need the evidence, and we've sort of come late to the evidence game. We were a couple of decades behind other comparable countries in terms of having good evidence to inform policies. I think we have. Some of it's still pretty awful, but we've got enough evidence across the board now to inform what we should be doing. But if you think of the big sort of successes in health reform in Ireland, one of them is the reform of cancer services. And obviously, it's a combination of factors, but that was really driven by our cancer registry. So having that good data to inform those decisions, and what the early cancer registry data showed was really poor outcomes. We were close to the bottom of the league table when we looked across European and high-income country context. And that, combined with a series of events, political interest, sometimes driven by personal interest, a series of crises in misdiagnosis, particularly of women in the mid-2000s, a political leader who was willing to take it on. Minister Mary Harney took it on. She appointed a clinical leader. Tom Keane came back from the States to drive that health reform. So I think that one is very much an example of evidence-informed policy, where that was a key part. But the evidence alone won't change the rules or the circumstances. So it's needing that sort of critical juncture or mixture of factors. And one of the academics I used in my PhD was John Kingdon, who's a North American political scientist, who talks about these policy windows of opportunity, and that they only happen when you come together with a policy problem, and that often involves having good data to back it up, and then a political stream and a policy stream, so a potential solution, they come together to open. So I think that's when evidence is important important. But equally, it can be ignored and shoved aside if people don't want to see it. I think probably another good public health example of evidence is the smoking ban in 2004. And again, that was driven by fantastic civil servant in the Department of Health, Tom Power, accumulating national and international evidence around the impact of secondary smoking. And that's really what drove the workplace ban on smoking, again, against the odds. There was huge vested interests campaigning against that. But he was lucky. He had Micheál Martin as his minister who wanted to drive it. Good evidence to back it up. Clinicians, I think clinicians are a key part of that mixture in health in bringing about that reform. If you have enough of those doctors on side, people might be more willing to listen to the doctors than journalists or academics or politicians. You know, they're sort of a safe pair of hands. But I think so evidence absolutely can play a role, but it can also be completely disregarded.
Right. So it can be a fulcrum across which levers, I suppose, you know, change things, or it can just be left out of the equation altogether.
Yeah, I think it can be really...
situation.
The other one I was thinking of was in relation to cystic fibrosis. And again, in Ireland 20 years ago, I think we had we've much higher rates comparably, but we'd by far the lowest life expectancy. And just bringing the data together on that of our really shocking figures around cystic fibrosis led to a really significant reform of cystic fibrosis services and hugely increased life expectancy as a result.
And in terms of who makes the policy, you know, that to me seems a little bit opaque. And when you're talking about clear communication, you've got to think about, well, who's my audience? What are they interested in, etc. So who are the people who actually use evidence to make policies? Where are they in the system?
I think that's a great question, because my experience is that it's more the permanent government, it's more the officials than it is the politicians. Until it comes to those big contentious issues, the big public contentious issues, yes, sure, it ends up being in front of the politicians, but a very large proportion of policy decisions that get made are really made more at the official level than they are at the level of, as it were, kind of, you know, open public debate and the day-to-day grubby business of politics. It's a lot of it is about persuading the people within the system that a change needs to happen and that the evidence is clearly pointing in a particular direction.
And that means understanding what their, I suppose, pain points are and what their interests are and what they need to do to get a policy to happen, isn't it?
And also stakeholders. Mm-hmm. I mean, yes, but the policymakers always worry about their stakeholders as well, because they've got professionals to deal with, they've got pressure groups to deal with, they've got politically active people to deal with, they've got special advisors to deal with. Being a good policymaker is really, really hard. I mean, I want to say this because I think there's a sort of narrative out there that, you know, evidence is a lever to get some sort of lazy civil servant up off their backside to finally do something. And that narrative is nonsense. These people work incredibly hard and they're juggling lots of different things at the same time, as I've just described. And so it takes a degree of persistence, and it also takes communicating that evidence not only to the policymaker, but to the other stakeholders that they have to take into account and think about in order to start to build a consensus that says, well, look, evidence is really pointing in a particular direction here. It's time to bite the bullet.
Sure. And how much crossover is there then, or how much can you distinguish between communicating about research to a general audience? So the general public, for want of a better term, is the ultimate stakeholder, I suppose, in all this, and then a specific policymaker. What are the differences in communication needs there, or are there any?
I'm not sure there are, but you probably do need different strategies to engage politicians or policymakers or the public. John Kingdon, who I referred to earlier, he has another piece of literature is about these policy entrepreneurs, so the people who really sort of mobilise change, and they can be within the system, so those civil servants. And I think often in health it is a brilliant civil servant or a senior HSE manager who tend to get not huge amounts of respect who drives that reform, or indeed a clinician within the system. I think in the healthcare system often it's those clinicians, but also sometimes it's from the outside. It's those very savvy lobby groups who just keep going, gathering the data, making the point, doing the press briefings in Leinster House, mobilising media, political, public support. I think then for other issues, if you think of the big changes in Ireland over the last 20 years, and marriage equality and the 8th Amendment to the referendum being two of them, they were very much where the public was way ahead of the politicians, and they were much more driven by, and it was only when the politicians copped on that the people were way ahead of them, did they begin to catch up. So I think it can vary depending on what the particular issue is.
Yeah, very good, very good. And what about changing behaviours as opposed to policy, changing health behaviours, like getting people maybe to stop smoking or to, eat healthier? What kind of engagement strategies tend to work better there, do you find, Pete?
If I could answer that, I'd win a Nobel Prize, actually. Changing health behaviours is famously difficult. It can be done. There are multiple behaviour change models out there. There'd be sort of 4 or 5 that my unit would consult on a regular basis. But what's interesting is, to me anyway, that it tends to be very context specific. That mostly when you're trying to change a behaviour, rather than a kind of general education and awareness campaign, it's much more to do with behaviour in a specific environment where you might want to change the way that environment operates. So you might want to make it more likely that people will walk and cycle rather than get in the car because you've changed the environment in such a way that they are more likely to do it because it now seems to be safe and it's more convenient. So rather than bombarding people with it's really good to cycle, that'll get your heart rate up, it'll make you live longer, these kind of messages, actually making the day-to-day lived experience one where living a healthy lifestyle is much more convenient, where the environment is designed to do it, but also where you communicate that, where you show that that's what you're doing for people and you say, look, we're doing this because we're trying to make it easier for you to do things that actually deep down you probably know you want to do anyway. Your long-term self at least is having a fight with your short-term self and we're trying to help your long-term self win.
And I think probably the one way not to change behaviour is just to tell people to change it, to sort of name and shame. And we know that on its own doesn't work. And I think the areas, again, of success is where we've addressed those upstream factors. So where those structural determinants have been addressed in order, and people given information and support and facilitated to change. But actually it's much harder to do that upstream determinants work than it is to just tell people to change. And therefore we tend to end up falling down that area of activity rather than really addressing the big public policy changes that need to happen.
And so what's the role here for, I suppose, co-creating or involving the public early on in that process of research and communication in order to change health behaviours or policies?
The way we do it is through diagnostic studies. So we will often run studies where we take people through different scenarios, we expose them to different hypothetical environments or even real environments sometimes, and we actually test how they respond to them. One of the things that I think is really important to understand here actually is if you're involved in a process, you use the word co-creation, what I'm describing isn't quite that, but if you're involved in a process where you're really engaging with the public and studying them and trying to change the environment in a way that helps them make better decisions, actually asking them directly often isn't particularly helpful. And the reason it's not particularly helpful is because I'm a behavioural economist or more broadly a behavioural scientist. I can absolutely tell you that for a large number of day-to-day decisions that we make, people have absolutely no idea why they do what they do. Right? They simply don't know why they make the decisions they do. And if you ask them in a focus group or a straight survey, why do you do this? They'll post-rationalise it. They'll come up with something because they've got to. You've asked them. So they'll come up with it, but they actually don't know. And one of the ways I know this is because we will run an experiment where we randomise people into 2 groups. We change one aspect of their environment, like we might change, for example, a study we run, we change markings on packages that point out kind of portion sizes or whatever so that they're really salient and visible. You do that, you randomise people into 2 groups, and one of them eats less of the food than the other and sticks closer to the portion sizes. Now, if you ask people whether they would fall for something like that, I've even used the word fall for something like that, right? They're going to tell you no, right? I wouldn't do that. I eat the amount I want to eat. I decide what I do. But actually, you don't. The environment that's around you is changing your decision-making behaviour all the time in ways that are subconscious, in ways that you don't know, or even if you do know, you might kind of want to deny because you want to feel like you have more agency than you do.
Yeah.
So yes, co-creation is a lovely idea in principle, and involving the public in what you're doing is important. So don't get me wrong, but there are limits to that. As a behavioural scientist, there are times where I can see one thing causing another that people might not want to accept is causing it, but from the point of view of policy, you kind of need to know.
And Sarah, what are your thoughts on that, on involving the general public, as I say, not a great term, but involving the public early on in that process of both research and communication about that research?
I think that context is really important here. And I'm thinking one of the hats I wear at the moment is I'm a co-director of the National Sphere PhD programme. And I'm thinking of one of our final year PhD scholars, Sophie Mulcahy-Simmons, she's an Irish Cancer Society scholarship doing work around cervical screening and why, trying to understand the low uptake among low income groups. And she's done some really fantastic work with women in low income groups going, this is the information you're presented, these are the letters, how could we co-produce this better? What would make you and your peers come to get cervical screening? So I think there's ways of really good practice that we're beginning to do that. But I think that context is really important, and how you target a group in an urban city environment might be very different to how you target a migrant group or a traveller group or people living in rural areas, because for them it might be a transport issue or a language issue or whatever. So I think context is important. But I also think there's learning at a more population level from, say, the citizens' assemblies and those exercises. And I think they're a really good example that if you give people good information and sort of a safe space and time, that actually not everyone will agree, but actually they do agree on most of it. Mm-hmm. And I think
this is where participants are selected. I think there's usually 100, is that
96
right?
or 97 or something like that.
Around that number. And they're really given the opportunity to do a deep dive with experts and discuss all these things. They're given time and space to really, get to grips with it.
And if you're anarchy enough to watch the proceedings or read the reports, you really see them going on a journey, the participants. Mm-hmm. And it's not that everyone agrees with everything by the end of it, but there's definitely that consensus and that sort of public good at a population level rather than people just concerned with their...
It's really interesting, isn't it, how in the age of polarisation, a citizens' assembly doesn't polarise. I mean, what you're describing is it tends to move in a consensual direction, even if it's the case there's some disagreement within it. And I think that's a really interesting thing, because it tells you, if we get democracy right, that you really can, co-create was the word we were using earlier, but do things in a consensus-oriented way where you're integrating evidence really well. I think the citizens' assemblies are very good for that. But even when you do a citizens' assembly, ultimately the findings then have to be communicated to that broader public and into that broader political sphere. So they're helpful, but they don't solve the problem for you.
But I think there are interesting learnings from them. And an experience of mine was working with the Oireachtas committee that devised Sláinte Care, that devised the current government reform plan. And for about 6 months, I was part of a team that supported their work. And again, we really saw that even though we had all colours and creeds from across the political divide represented on the Oireachtas committee, actually on really controversial issues, you could get most of them to agree on most of it. Now, not all of it. Not all of it. There was still. Yeah. So again, I think where you have that good information, a safe space, room for discussion,
time for discussion.
Yeah, different opinions being brought in, that you can get a much better result, be it a public policy.
I think the other thing they do, you're right, of course, you're exposing citizens to much, much better information, but it's also something to do with trust for me. That when people go into a citizens' assembly, they get exposed to good information, but they also get exposed to the experts who feed that in, and also to the policy-making system to some extent, and the idea that there are officials who are trying to be impartial and are trying to actually find consensus. So it's partly the kind of trusting relationships that get created as well. And I think that also includes important lessons. We kind of often have this model of how people decide things that says, they pull in information, they weigh it all up, and then out spits a conclusion. But there's an awful lot of human stuff as well as information that's to do with trust, to do with empathy as well. That's a really big one. In some of the citizens' assemblies where you hear from people at the sharp end who are really being affected, that can really change your view about a policy, because you start to develop empathy and understanding for the people who are suffering the consequences of the policy or might suffer the consequences of it. So a lot of it's actually about that human connection as well as just the information and the evidence. And as a scientist who trades in statistics and evidence, that's something you really have to think about, because quite often that human connection, that empathy, that narrative, that one individual who's got the story to tell can be far more powerful than my statistics.
Yeah. And
often indeed. And I'm not saying that's a good thing, but it's the reality. Also, I think there's a real shift. Like if you were to think about how did governments make and implement policy 100 years ago, it completely was middle-aged white men in government departments deciding with politicians what to do, and that was it. It's very different now. It's so I think there has been that it's been traditionally very top top-down. I think it still largely is very top-down. But I think when we see examples, like I mentioned earlier, marriage equality, the Eighth Amendment, that when it's bottom-up, that can be really powerful too. And I also think, say, the reform of the cancer services, what really worked there was the clinical engagement of everyone on the front line. And Tom Keane went around the country talking to everybody, nurses, OTs, physios, going carers, relatives of people with cancer themselves, going, what can we do to provide the best cancer care? So I think we need to do much more of that bottom-up policy making, and that engages people, that gives them a sense that this makes sense to me and my family and my village and my community, rather than Dublin is telling us what to do or what should be in our hospital.
And is that one of the pitfalls that health researchers might fall into when they're looking to influence policy, where they're really just focused on their research and not thinking about that application in different contexts?
I'm very influenced by a model actually that a Canadian called Best produced, where he talked about 3 levels of research and policy, the way research informs policy. And the very first level is just supply and demand. That, the researchers supply the evidence and the policymakers kind of demand it. And the researcher's job is simply to supply the beautiful research paper or the research findings or the PowerPoint presentation or whatever it is. And that's the job. And then it's the job of the policymaker to then integrate that into the policy and use it accordingly. Now, Best identified that as the first level. That's like first base and the least effective level of informing policy. And I think Best was absolutely right about this. And then from there, you go up to what's called the relationship level, where as well as that, what you have is a relationship between the researchers and the policymakers. And for me, that's the really important step. I mean, I know that the evidence that my team produces has far more impact when we have a good relationship with the decision makers and when we have a direct relationship with the decision makers. They can listen to presentations and they can read the stuff. It will never influence them as much as if we're actually conversing about it. And that relationship really matters. And then finally, you've got a system level where you actually embed researchers within the policymaking apparatus. Now, that's hard in a small country like Ireland because we have capacity limits. It's very difficult to have enormous numbers of researchers. It is. We have more specialists now in the civil service and in agencies and in departments and so on, but we're always going to have capacity limits relative to larger countries. Of course we are, because that's the nature of a smaller country. So we have to have really good relationships between our researchers outside the system and the people inside the system as well. But I go back to it, the relationship really, really matters.
And for researchers who are not sort of, having conversations with policymakers all the time, how can they get into those conversations or even become more aware of what they need to be doing to get into those conversations?
I think starting small, building up your allies, building up your network in your area of expertise, whether that's a particular disease group or population or whatever it is, and just putting yourself out there. Like, again, we do this on the PhD Sphere programme. There's a lot of having to present your research, getting it down to elevator pitch, how you can communicate it to your granny clearly, how do you write a policy brief, going to conferences, going to international conferences. Often you've got to sort of prove your weight internationally to be respected in an Irish context. And when you have that big journal publication or presentation, then it's actually easier to open doors at home. But also for me, it's a bit like, farming or community development or something like you have to be in it for the long haul. When I did my master's in London School of Economics, and I did the best course I've ever done in my life on social research methods with John Hills, and he made us read all the great texts, so Townsend, Rowntree, all the great British social policy texts, and then look at when the research was done and when they influenced actual change in law and people's lives. And that was 2000, and I found out it was 20 or 30 years, and I thought then, oh God, no, I was young, and I thought, no way, I can't, I'm not going to be. And here I am, 25 years later, still doing that work. And I think there's a role for lots of people in different places, whether it's in NGOs, in the health system, in academia, in organisations like that, to be there for the long haul, sort of holding the people who move through more quickly, often our politicians, to account to deliver on that change. But you've got to plant the seeds, you've got to plough the land. And I think it's that long haul work. And obviously change happens quickly, but most of this stuff, it takes years or decades to bring about that change.
That's really good. But I want to go back to what you said at the start, because that definitely resonates with me. I mean, I mentor people in the SRI. I've got a young team, and when you're giving them advice, the most simple way I can put it is go to stuff. Get out there and go to stuff. Attend things, be at stuff, see stuff, talk to people, take any opportunity you can to present in front of people you haven't presented before, especially. Get out there.
Put your hand up at a conference, introduce yourself, make a point.
Get out there and communicate.
Post about it.
Because it isn't just that you're raising your own profile by doing that. You're picking up skills as you do it. You're developing relationships as you do it. But you also watch the people who are really good at it. Mm-hmm. You get into the environments where you see the people who are really good research communicators who are forging the relationships with the policymakers, and you pick up what they're up to and how they're doing it. So you've got to get out there and do things. Now, for some researchers, that's really hard. I mean, we all know researchers can be pretty nerdy. They're sometimes much happier interacting with a computer terminal than they are with a human being, because I'm a nerd. I love interacting with my computer terminal, especially if I've got new data to play with. That's great. But you've got to get out there and do stuff with people.
And also, I think people can learn it, because people would say to me, oh, that's something either you have or you don't have. I don't agree at all.
Yeah.
I think and I've seen it. I work with some absolutely fantastic early mid-career researchers who would have been shaking, like they'd have been feeling ill before presenting. They'd have never done in person because of COVID. And now they're just brilliant, skilled mid-career.
They've built their confidence with it as
but
well.
It's just practice. It's practice.
It is.
I did a weekly radio slot every year for 7 years, and it was 7 or 8 minutes, and I did 7-10 hours of prep every week for that 7 or 8. It's practice. You do it regularly, you work hard at it, you over prepare, and then you get good at it.
You do.
I don't think most people inherit it. It's not genetic,
Something I do hear from researchers, though, is that they don't feel they have the time to do that, and maybe they're not incentivized to do it. Do you think maybe there's a role for even funders to make a little more time and space for this kind of activity?
Absolutely. It's not sufficiently built into the way research grants operate. But I would have more sympathy for your incentives argument than your time argument. Okay. Because I think those two are actually interrelated. I mean, yes, the problem is that the researchers only really have incentives to publish. From a career point of view, you get far more rewards from publishing papers and putting your paper count up than you do from getting out there and interacting with people in the real world who are stakeholders or policymakers in the area in which you're putting the research. But you do have the time to do that. It's just, unfortunately, the system is making you trade that off against the incentives you face for getting jobs and promotion. And so the incentives is the real problem here. Now, I say that like there might be an easy fix. There isn't, because it's really hard to measure the softer stuff. It's really hard to measure the communication stuff, even though it matters really, really well. It's very easy to measure how many papers somebody is publishing. So you end up having to have a kind of subjective view of someone's effectiveness as a researcher. And I think we have to accept that. I mean, you can't measure everything and you can't make everything a league table. And I think academia has gone far too far in the direction of making everything a league table.
And I think I would argue, well, it should be core to what you're doing. And it mightn't be that everyone wants to go and do a podcast or a radio or a TV show, but there's different ways you can communicate. But I think if we're being paid, and most of us are, out of public money to do research for the public good, then that's part of the gig. Get out there and communicate it, and communicate it well.
So stepping back a little bit and taking more of a helicopter view, what do you think a more effective ecosystem for research to policy or behaviour change would look like? Like, what needs to change? We've mentioned a few things already, but what stands out for you as the things that need to change for that research ecosystem to have more effect on policy and behaviour, particularly in health?
Some of the stuff Pete has talked about, that the nature of our grants, how we win money, to which we all have to do to bring in research and researchers, or how we get published, the nature of it is competitive, right? You compete and you win or you lose. But actually, to do effective, good policy work, it's collaborative. It's those really positive relationships with key stakeholders, with the public, with communities, with the people in positions of power who make those decisions. So how you make what is inherently competitive, collaborative and still fair, I think is a tricky one to do. But I think more rewarding, like we've begun to do it, say in the HRB has begun to do in the Implied Partnership Awards, or even the Evidence for Policy grants, where the people making the decisions are setting the research questions or the research areas. I think that lots more of that, which makes it collaborative. It's still competitive, but there's a collaboration built in rather than just competition. And the competition means we're competing against each other rather than working across sectors and universities and agencies.
It's a different mindset. Yeah.
So I'm going to add to that. I agree with all that, but I'm going to add to it, and I'm going to say something mildly controversial in the sense that we need talking shops. And what I really mean by that is, of course, not the sort of pejorative use of talking shops. What I really mean is we need more spaces where the researchers and the policymakers are interacting, because that's where the magic happens. Now, that doesn't mean, more workshops and conferences where people are standing up and giving, lengthy presentations. It's about actually having the relationships to work. Now, interestingly, one of the things that we do with our lab quite often is when we start doing research with a new client, we also do training for them in behavioural science, where we'll actually give them a one-day training course in some basic behavioural science. And through doing that, you get this really, really lovely interaction, which then means that maybe the research and policy relationship is going to get better as a result of the interactions that you have. That's the kind of example that I mean. So I think events that are not the sort of routine workshop and conference, but are actually real opportunities for people to share experience and discuss what their job is really like and the decisions they really face. And researchers come out saying, well, look, this is the things that we really want to work on. These are the things that we really can answer. These are the methods we use. These are the things that we can't. I find there isn't enough space for those conversations. I have to have them, on the side events at coffee. And we need to build an ecosystem where those interactions, and I don't know exactly how you do this, but where those interactions are a more routine part of what we do. Because my experience is, where researchers inform policy really successfully, it's nearly always because those relationships have been fostered and are working really well.
Right. And also, I think there's something really strong about Ireland being only 5.2 million, because it's actually when I talk internationally about the access I have to senior decision makers in the political system, in the health system, whatever, they cannot believe it. We're unusual in that. So I think that gives a real opportunity for that collaboration. But much more of, my first job before I went to LSE was in the Department of Health. I've worked in the NGO sector. So working in different places means that you have those relationships with people across the board, right? So going those traditional career routes, which unfortunately I never did, sort of mitigates against that cross-fertilisation of ideas and skill sets. And, people in government departments don't really understand how academic research works, and vice versa. And if there was a much greater understanding of what the needs are of each side, then maybe that cross-pollination, that working together could happen much more effectively.
So some of it is about managing expectations on both sides, the policymakers and the academic researchers, even around things like timelines. How long does research take? How long does it take to have an impact? Can a policymaker ring up a researcher and say, I need a very specific answer to a question? Is that a reasonable thing to do?
I think that's a really good question. Those early engagements and managing expectations and getting an understanding are super important. I've had experiences where I've been phoned up by a senior policymaker who's saying, look, we're really interested in this. Can your team help? And they'd tell me what the question was. And I'd say, yeah, I think we can help. And then the next question was, how long do you think it would take for you to answer this question? And I said, well, actually, it's a priority. There's a lot of importance here. I'd say we could probably get an answer to that in about 4 to 6 months. And that's the last I ever heard of them. Because somehow they think we can magically pull a research finding that would have required, a nationally representative sample of 2,000 people and the whole programming and study design and all the things that come with the research. They thought we could just kind of pull it out of the air, So, there are real misconceptions. That was a senior person I was talking to, that there are these kind of misconceptions that happen. So, but that goes back to my point, I think, about relationships, that's how you start to understand how each other works. And we've talked quite a lot here about kind of misconceptions policymakers might have and understanding research. Well, it really works the other way around as well, that researchers, in my experience, often think you can deduce good policy from research evidence, and you can't. Any policymaker is juggling multiple things. Even if the evidence is pointing strongly in one direction, they still have to decide, okay, even if I know that's going to work, is it my biggest priority? Or is there something else over here I should direct my staff and money to that's going to have a bigger effect? Or, and then I've also, any change I make is going to involve changes to jobs and people's roles. And there's always risk involved in that. And I've got to weigh that up. And that's the policymaker weighing that up. The researcher doesn't know anything about those things, the context in which they're working. So it's also about researchers understanding the limitations and the difficulties of being a good policymaker as well.
Mm-hmm. Absolutely. And all this is so important for that communication to happen, because if there are unrealistic expectations on either side, then communication is not going to be as effective as it would be otherwise, and nor are outcomes. But I suppose, to round off, what advice would you give to researchers in health who want their work to have a real world impact beyond publishing that paper?
I think we've talked about this already. It's like Get out there. There's, it was called shoe leather policy making in the UK in the 70s or something, because you'd be a man with leather shoes that would be worn down by literally doing the rounds of Whitehall and getting out there. So go to conferences, go do media, even if it's very small local media, upskill yourself, stand on the shoulder of giants, make good relationships with people more senior than you within your institution and in key stakeholders.
I think that's absolutely right. So I'll add one technical thing as well, which I think also matters, which is this. Quite often, the interface between research and policy isn't clean enough because the question hasn't been accurately enough identified. So actually, if you're a researcher who's trying to make your way and you're looking at a particular policy problem, a lot of the skill, if you want to provide evidence that really changes policy, is to identify the right research question. What is the research question that, if I can design a study to answer it, changes the game? Which are the questions that actually would change people's perspective, would make any reasonable person looking at the policy problem go, oh, now we know that, maybe we need to be looking here for a solution. And identifying the research question, we always think of the skill as the researcher as being answering the research question, but identifying the right one is a really important skill if you want to have influence.
Very good. Well, thank you so much to Associate Professor Sara Burke and Professor Pete Lunn for joining us today on the podcast. And remember, you can listen to all episodes on major podcast platforms and on video on the Health Research Board YouTube channel. You will also find links to audio and video versions on the website hrb.ie. For now, though, slán, and thanks for joining us on the Health Research Podcast.